like a medical meeting, guys. We're here. Okay, here's my, I never know what this guy's going to say. It's scary. Thank God. Okay, again, do not talk about your symptoms.
About 4 months ago, I had severe pain in my left buttocks, which began to work its way down the back of my hamstring into my knee joint, and then down into my ankle. And every morning I woke up, my first step out of bed brought tears to my eyes. It's like walking on a broken ankle. It took about 4 or 5 hours of the day to finally work my way through it with Percocet or ibuprofen or some kind of drug to calm the pain. And I realized I needed more help than just what I was doing.
Did you have injections?
Yes, I went to a pain management doctor, which did absolutely nothing. They did Facet injection, I think it's called, and Fixet block. I don't know what the technical term was, but they did injections, which did absolutely nothing. They put me on some physical therapy program, which did absolutely nothing. And I went to...
How long did you have pain for?
Probably, it was severe for about 4 months.
And then you had previous surgery, right?
Oh yeah, 10 years ago I had a similar situation of the left side sciatic pain where walking was impossible for about a year. It would take me an hour to get into New York City on the train. My office was a block away. It took another hour to walk from Grand Central to 45th Street, which is a block. It was so severe I had to take 2 steps, catch my breath, and start again. It was brutal. I had surgery. It's been gone for almost 10 years, and then it came back and reared its ugly head.
I'm going to have you walk down this hall here. Now, when was your surgery? 10 days ago. No, okay. 10 days ago, we took him to the operating room. This is a little different. We used some miniature rods and some bone graft, a little bit different than just using this, but the same concept of less invasive. You notice here's a little, we just have a little, it's a little Velcro brace made in Germany. We have different ones we use, but no heavy plastic brace. He's, what medication are you on?
None.
So he's 10 days post-op.
I operated Thursday. Friday they had me sitting up and eating and walking. Saturday morning, Dr. Eidelson came in and said, go home, get out of here.
Okay, so it's inconceivable. We're going to continue. He says he's... A lot of people I treated a guy, I saw a guy yesterday that came from Naples that had a defibrillator, a mechanical heart valve, there's an insulin-dependent diabetic, and 2 knee replacements. They wouldn't touch him in Naples. And I went in and put a little rod and a device like this in there, and he left in 2 days. It's inconceivable. Not only that, a lot of people don't get surgery because they have atrial fibrillation. Anybody here with atrial fibrillation? They're on Coumadin or whatever, and the doctors won't let them stop it for long periods of time. With these newer, smaller surgeries, we can start the blood thinners 2 days after, 1 or 2 days after surgery. So there's a lot of other factors that come into play when we do less invasive surgery. And obviously the goal here is to lower the complication. Most of the people I see over 60 have what we call comorbidity. They have a heart problem, they have a kidney problem, they have something else besides their spine. Those are called comorbidity. The more comorbidities you have, at least 2. Let's say you have high blood pressure and a cardiac arrhythmia. Your complication rate in spinal surgery with traditional surgery is much higher. So we want to do things that are less invasive. That's one of the reasons I worked on this. Because these types of surgery, 1 hour, 1 hour and 15 minutes, I can actually do them under local. I started doing them under local, but it was actually safer to do it. It was safer to do it under anesthesia because people are face thin. These are done in the hospital. So I'm going to stop and take some questions because they're always, okay?
I have basis and I'll be the patient. But that's not I'm
So the question was, she has stenosis and she hears a clicking in her back. So again, a lot of people go to the doctors and they talk about the disc. But most of the time, if you look at the spine, the actual model of the spine, you We've got the vertebrae in the front with the disc. One in the back where the lamina. The reason we call this surgery, when you take this out, called a laminectomy, is they remove the back of the spine called a lamina. Just like an appendectomy needs to remove the appendix. There's a little joint on each side of the spine, just like a knee joint. It's a hinge or an elbow. We have a hinge on both sides of our back. When these discs start to narrow, these hinges get out of whack. It's just like an old door. Why does a door that's 100 years old squeak? It doesn't quite fit right, so we can oil it, and maybe that'll work. That's kind of like an epidural. But if the hinge is actually bent, because it's just not working, you got to fix the hinge, or you got to change something. So these devices are partly done to change the orientation of the bone in that joint. So clicking isn't a problem. It's clicking that hurts is a problem. Now this device called an interspinous process implant. There's about 4 or 5 on the market. Well, this one's called the Aspen device. But there's the X-Stop, the Aspen. There's several. I helped develop the indication and a new type of using this in combination with other things. So people that they thought we couldn't use this on, even people that have had previous surgery. This is kind of what I've done. I've done about 1,200 of these implants. Well, I don't like to discuss individual care. Look, there's a lot of, the question is, he's had injections, medication, he has stenosis. His surgeon has been talking about surgery, and he doesn't talk about the devices. Look, we're creatures of habit, and I always agree with surgeons. Do what you do best. That's the biggest thing, you know. We live in a very specialized world. When you talk about spine, you don't want a heart doctor who's only done 2 bypass surgeries in the last year. Now, in our website, there's a lot. I think it's important today people get a website, see the credentials, publications of their physician. I don't say this is for everybody. Every doctor has their approach. I particularly believe, for me, and the vast majority now, look, when I did a couple hundred, but now I've done a couple thousand, and I've published quite a bit. And it's not a perfect answer, but the beauty of this, it's like a cardiac stent. 25 years ago, if someone says, I'm going to put a stent in your coronary artery, and you only find they thought it was impossible, it won't work. Now 95% of coronary artery, serious is treated with stents, and maybe 5% with bypass surgery. You're going to see the same thing happen here. It's hard to change in medicine, and that's the problem. A guy can have a great bedside manner, be well trained, but he does what he does best. There are many different ways to do things that work, so I have no problem. I don't think this is the answer for everything. I am totally open-minded, and like in this patient, I use a combination of traditional surgery and new surgery. So there's various things. What the doctor has to do is what works for you based on his experience.